As the crew arrive to the scene, the patient is continually fitting.
This was a very complex case.
Even after they gave the first dose of the midazolam, the seizures weren't going. And that could be a sign that it was resistance to the treatment, and that could then eventually lead the clinician to sort of gathering the evidence that this is likely going to potentially be, a terminal event.
So we're joined here by the Karina Catley, Natalie Nabunya, Rowena Rickson and Jodie Grace. You'll have heard them on the previous 3 episodes we've done on palliative and end-of-life care. So today we're going to dive into these real-life cases. We're going to discuss the expected death where religious beliefs guided a family wish to keep their loved one at home. There's cultural and religious wishes that come into play. How would you unpack things with the daughter? So welcome to this episode of the Principal Care Podcast with me, Owen Walker. In this episode, I'm joined by London Ambulance Service Palliative and End-of-Life Care team this morning in a podcast studio. So it's fantastic to have you guys. I'm joined by Karina Catley, Natalie Nabunya, Rowena Rickson and Jodie Grace. You'll have heard them on the previous 3 episodes we've done on palliative and end-of-life care. So in this episode, slightly different, what we're going to do today is really unpack different clinical case studies just to contextualize some of the information we've heard in the past 3 episodes and really frame them in clinical case scenarios to really contextualize some of the information you've already heard. So today, we're going to dive into these real-life cases, really unpack some of the challenges and humanity at the heart of this work. So what we're going to look at is our first case around seizures and indeed shared decision-making. And we're going to meet a patient in the community experiencing uncontrolled seizures, also with incomplete documentation and difficult choices between hospital transfer and or remaining at home. So the case study really does unpack some of the realities actually of palliative and end-of-life care. And we really want to keep it true to its initial core. So we're also going to talk about the doctrine of double effect. We're also going to look at the role of specialist palliative care teams in that case study and indeed how shared decision-making shapes these moments. So our second case, care after death and indeed cultural sensitivity with the family. We're going to discuss the expected death where religious beliefs guided a family wish to keep their loved one at home. We're also going to examine the legal frameworks, public health considerations, and indeed how clinicians can honour cultural and spiritual values while supporting grief. So we're joined here by the palliative and end-of-life care team. We're also really going to dig into, in the conversation, some of the nuances and details and insights that the team can really give us through being involved in this work for multiple years. So welcome, Natalie, Rowena, Karina and Jodie to the podcast.
Thank you for having us.
Thank you.
Excited to be here.
Yeah.
It's great to have you all with us, actually. I'll just start with Natalie. Natalie, can you just unpack we've heard a little bit about you in the past few episodes. Can I just get you to introduce yourself?
Yeah, so my name is Natalie. I'm a clinical nurse specialist by background. I now work part-time with the London Ambulance Service as a Macmillan Palliative and End-of-Life Care clinical nurse specialist. I just started at the beginning of this year.
Fantastic. Karina, to yourself.
Hi, Owen. I'm Karina Catley. I'm the Macmillan paramedic lead on the end-of-life care team at LAS, so been a paramedic qualified for around 11 years now.
And Jodie, to yourself.
My name's Jodie. I'm a Macmillan paramedic associate with our end-of-life care team at the London Ambulance Service. I've been with the London Ambulance Service for 20 plus years and joined our end-of-life care team about 2 years ago now.
Fantastic. And finally, Rowena.
Hi, Owen. Thanks for having us. My name's Rowena. I'm a Macmillan paramedic associate with the end-of-life care team at London Ambulance Service. I'm also a paramedic. I've been with the service about 10 years.
Fantastic. So what I do before we start and really dig into these clinical case studies, which really present a lot of learning to us, I thought we would initially come to Natalie and Rowena just to maybe contextualise, why you joined the team and why palliative care is fundamentally so useful to be embedded within an ambulance service. Natalie, could I just unpack maybe some of your sort of origin story and why you're part of this team?
Yeah, thank you. So, my journey in nursing started as a ward-based nurse, supporting patients specifically in oncology. I was drawn to palliative care because I found it quite important to look after people in life and through illness, but also at the end of their life. I thought that was quite important. But one of the more poignant moments for me in terms of palliative care specifically was when one of the palliative care nurses came up to the ward to see a gentleman who had no next of kin and initially had really wanted to be at home, and it was quite difficult to get him back home just because the support wasn't quite teed up as we had wanted it to be. And there were some things that he had wanted or enjoyed in his life, and that was, having a particular beer and enjoying chocolate and just wanting to be outside and not be in a ward environment. And I think what touched me was how this nurse, this palliative care nurse, wanted to emulate that for this man. And so what she went and did was she went and bought him his favourite beer, she went and got him his favourite chocolate. And in terms of how the layout of the ward is I don't know if you're familiar with Nightingale wards, which are these long bays and, all the patients are just facing each other. And what she did really just touched me was that she turned his bed around to face a window and she raised it as high as possible so that he could look outside. She opened the window just ever so slightly, gave him his beer and his chocolate. And I thought, that's what I want to do. That's how I want to care for people, and I want to make a change in their lives. So that's one of the moments that touched me the most, and sort of here I am now, and just joining the London Ambulance Service. I think just looking at how things are progressing in terms of how we provide community care, I thought this would be one of the places that I would have a more of an impact on in terms of keeping people at home and where they want to be specifically, and just making sure that we're all involved in their care, how they need us to be involved. So I think that's a bit of my journey.
Listen, that's powerful. That's powerful. Yeah. Absolutely powerful. Yeah. Rowena, to yourself.
So I think clinically it's something I've always been interested in, but actually the moment that sort of galvanised it for me is quite a personal one, which I hope you don't mind me sharing with you guys today. So my mother-in-law was unwell with pulmonary fibrosis, and the morning that an ambulance came to take her to the hospice, which was her final journey to the hospice, I'd already been a clinician for about 5 years, so I was really familiar with the ins and outs of that process. And when the ambulance arrived, there were two very young clinicians, which is absolutely no disrespect to them at all. But the sense that I got from them was just fear, was just absolute fear in managing this patient, this person, and what was probably quite a lot of family in the house at the time. And actually it ended up with us reassuring them that what they were doing was okay, that we were okay, that we knew what was happening. And I think it just made me feel like we can do better and we need to do better. And I think that's such a driving force for me it's about equipping our clinicians to go into that scenario feeling confident and feeling like they can manage not just that patient and what they need, and importantly what they don't need, which is not to worry about their observations because they're not going to be good, but also to manage the family in that moment. And I can still remember what those clinicians look like, and it's coming up for 5 years ago now. So I think for me that was the kind of galvanising moment that made me think I want to be involved in doing better and being better for patients, for families and for clinicians, because actually it's really important that they walk away feeling like they've done a good job as well. And hopefully being part of this team in London and working a little bit more outside of London as well, trying to drive forward the national work, that's hopefully something that we are influencing and improving. So that's, I guess my origin story.
Yeah, listen, equally as powerful actually. And to your point, and to Natalie's point, I think this team is equally as beneficial for staff, as you're saying, as it is for patients, because it's that sense of confidence through education, confidence through debrief, confidence through feedback that actually, you're right, Rowena, empowers clinicians to to understand, we are doing the right thing here. And actually, as Natalie has said in the last episode, really is around that MDT approach. So there's always a guiding hand in the background saying you are on the right course, you're doing the right thing. But you're right. So that actually the family don't end up having to support the paramedics. It can be, it can flow more to the family, and just that reassurance through the confidence is powerful. Okay, so just before we start, something that's prudent to say, and we agreed this beforehand, is that just want to give a trigger warning for these clinical cases, because if there's anything you hear in these cases, it might be quite emotive. It probably will be quite emotive. It may land quite close to home, but it really is a powerful way of framing information. But just want to put a trigger warning out so that any of this information, if you feel this is maybe a bit too close to home, please do be judicial at proceeding. I think it's equally as important to frame information in this way, because these are real life case studies which have happened to crews, and the palliative and end of life care team here, these guys have had to debrief and indeed unpack and deal with, and there is some significant learning here. Okay, so the first clinical case study is a patient in the community. As the crew arrive to the scene, the patient is continually fitting. So there's seizure activity on arrival. So the medication authority and approval record or chart is incomplete. And again, that's not necessarily uncommon, sometimes can happen. So the specialist palliative care team are involved in this patient's care. The seizure activity is difficult to control on scene, true to say. And the fundamental decision for the crew is really around do they transport quite promptly and immediately this patient to the emergency department, or indeed manage this patient's care at home, as this might be a terminal event. So this is really the first clinical case study. So midazolam is given at home, but the concerns about the doctrine of double effect arise, and we're going to talk about the doctrine of double effect, what it means, what it is, and also just so the crew do seek that MDT approach, that multidisciplinary team approach. They liaise with the advanced paramedic practitioner in urgent care for extra support, and that's a remote access in the emergency operations centre just to guide their decision making. But let's just talk about this, because this is I think fundamentally initially there's this recognition of seizure. Is it a terminal event? Is it not a terminal event? Karina, I'll come to you first. Really, could I get you to maybe unpack just what signs that this could be a terminal event?
Yeah, I think just to say firstly that this was a very complex case, and something that one of the palliative care consultants came to us because she was quite concerned about the crew and how and thought they did a fantastic job at managing this very, very complex, high stress situation. But yeah, in terms of seizures being a terminal event, I guess the key learning point is you won't know. With a lot of these things, you don't know it's going to be the terminal event. However, it's all about your history taking in the period up to that. How has this patient been? Have they had this gradual decline? Is this seizure on a baseline of actually they have been declining week on week, day on day, which might indicate that there's a potential for this seizure to be the last one. However, I mean, I'll throw it out to Natalie, because obviously you have a lot more experience in this. But in terms of our treatment, this is absolutely something we would treat, even if we believe that this may be a terminal event, because of the comfort of the patient as well as the family witnessing that as well.
Yeah, thank you. I think it's more around what the context is and the history taking, because, most of our patients do have terminal illnesses, which they eventually will die from, and that could also be considered a terminal event. And in this context, it's more around emergent situations. So it could also potentially be things like catastrophic bleeds that we would consider terminal events, specifically in palliative care, and we would attempt to plan for and put things in place to try and manage those emergent situations. I think with this lady, as Karina said, there was a history that she had some electrolyte imbalance, but we'd want crews to think about, do they have brain metastases or a brain tumor? Is there something that's going to prolong this and cause it to continue, I guess, manifesting? But in this particular case, even after they gave the first dose of the midazolam, the seizures were ongoing, and that could be a sign that it was resistance to the treatment, and that could then eventually lead the clinician to sort of gathering the evidence that this is likely going to potentially be, a terminal event. So it's thinking about, what's the history, what diagnosis have they got, and if it's not responding to treatment, what do I think is going to happen next?
No, yeah. Indeed. So, Karina, I'll come to you and just ask you really how that changes the approach to your clinical approach to in the moment, because as Natalie said, if this, if there is no subsistence or termination of the seizure activity with midazolam, but actually we do want to, as Natalie said, really start to smooth the path for a peaceable death. What's the escalation of treatment in a case like this where there is no the midazolam isn't working, the patient is still got seizure activity, that obviously there might be quite a lot of anxiety with the crew. What would we do then?
I think that the crew did an excellent job in this case about seeking senior clinical support, and they did that via the critical care APPs in this case. And our critical care APPs have PGDs for midazolam, so they're able to give a slightly higher dose than our paramedic crews would give. But I think they did a fantastic job in doing that shared decision making really early. And they also involved the palliative care team early, and this palliative care consultant was on the phone pretty much the whole time with them, trying to manage the crew's anxiety around this situation and the medication, as well as trying to support the family and the patient in staying at home, ideally. But yeah, it's all about escalating it and realising that these are quite rare events. They're quite stressful events that actually this crew didn't need to hold this on their own. They did absolutely the right thing in getting a critical care APP there, who was fantastic in being able to manage that situation, and liaising with the palliative care consultant throughout. So shared decision making really came into its own in this case.
Yeah, and if I could just add, it was a shame that the medication authorization and administration authorization record was not completed accurately, because usually there's a section in that chart that allows you to prescribe for a crisis event, and generally that dose of midazolam or the benzodiazepine potentially would be a lot higher, give you a much wider range that you could then utilize. And when you do recognize that this is actually a terminal event, that allows you to use that specific dose range to administer, but it also allows you then to speak to the family and explain to them that, I feel like this is likely going to be what ultimately leads to their death. And so it puts you in a different position than a position of where you're trying to reverse something or trying to treat something, whereas now that's not going to be possible anymore. I just need to manage and control this symptom at this point. So I think it can change the headspace slightly and give them a bit more confidence and to just push forward. Yeah.
So absolutely, and to your point around, actually there is almost a plan A, plan B, plan C in place, which is consistent with treatment escalation, but it's evolving, and there is an accurate documentation in the process. So could I get you to, is there any ways or indeed strategies really of confirming medication histories on scene? It's super difficult, isn't it? Because you've got a patient that's fitting, you've got an incomplete medication authorization and administration record. You just want seizure termination. Whatever you're giving isn't always working. Like we said, the pivot initially is share the oxygenation, share the decision, look at a quick escalation of decision making. Would you involve families at this point? Just trying to get a quick semblance of what's been given, when it's been given. Would you go to these, because specialist palliative care were involved, but takes a time to get them remotely involved. Would your initial pivot be to the families and then specialist palliative care? How would you go about that?
I mean, I think it's important to utilise what you have on scene, and especially in emergent situations. If a family is present and, what they're telling you fits the narrative, then I think that's something you can take on board. But, we also have the universal care plans, and those are really good resources to look to and see what is documented on there. Potentially you might have a discharge summary. So paramedics are generally quite good at actually looking for the evidence in the home and, asking the right questions about what would you take if you needed it for this particular situation. So I think it's being that investigator and trying to get all of that information. But with these particular cases, it can pose a challenge because of time. You want to treat as quickly as possible. But if you have people on scene, if there's multiple paramedics on site, you can delegate tasks to each one to say, you go find that out, you find this out, I'll call a palliative care team and try and escalate this. I'll call the CSD desk who can also support with that. So there are options available.
I think what's unique about this, and I think a lot of the time we say, take your time, share that decision, but this was a situation where actually they did need to act really quickly, and like you said, Owen, about the putting the oxygen on, etc., that was absolutely the right call to, in the first instance, try and manage that seizure whilst you're getting that advice. But I think I echo Natalie's comments that as ambulance clinicians, we would naturally speak to the family first and say, have they ever had really difficult to manage seizures before? What happened before? Who's involved? And getting that history really rapidly, I think, is something that as ambulance clinicians we're quite skilled at. It's just a tricky case that it was a palliative care patient that had been expected to die within the next few days and had this really, really awful symptom to try and manage as well, with limited documentation to support the ambulance crew. So they were just caught in a very unlucky, and the patient in a very unlucky situation, but luckily got the support in the end that they needed.
So let's look at the doctrine of double effect, actually. Just for listeners unfamiliar with the doctrine of double effect, maybe could we just unpack the term and what it means?
Yeah, I mean, I first heard the term when I was studying palliative care. I'd never heard the term before, and I don't think I've ever heard it applied to any other part of pre-hospital practice, actually. But it is an ethical concept about how an action you have could have two effects. Usually they describe it as something, a morally good effect and a morally bad effect. So in terms of, if we relate it to palliative care specifically, and this case, it's around the administration of medication. So in this case, the administration of midazolam, it would have the intended effect of the ambulance clinician giving it is to stop that seizure, but the unattended potentially harmful effect is that it may hasten death. It may bring about death sooner than would have otherwise happened. So it's kind of that ethical dilemma, but the concept talks about the fact that as long as your intentions are good, you're giving it to stop that seizure, you're not giving it to hasten death, then it's morally sound. It's a morally sound decision. And I don't know if anyone else has heard it in relation to any other concepts of pre-hospital care, but it's spoken about quite a lot in palliative care, isn't it?
Yes, yeah.
Sorry, I didn't know if you wanted to add anything.
No, she's done quite a good job. So I don't feel like there's much to add. I mean, that is the goal, is to support, to manage that symptom, but unfortunately you're likely to have that effect of potentially hastening death. Yeah.
And I believe in nursing terms, certainly this isn't something that perhaps is pre-hospital, but they call it the last injection sometimes as well.
Yeah, it can be commonly referred to that. We try not to use it often because we don't want the misconception that the public has a misconception that we're giving certain medications to hasten death, because generally what we say is we're giving what the individual needs to manage their symptom, and if there's a likelihood that they do die following that injection, it's not necessarily the injection that's caused the death. It's because we've controlled the symptom, and so it's just having to be clear about what we're saying, because in this particular case it's slightly different. Whereas if you're just doing symptom control for somebody who has pain, the aim is not to hasten death, and usually the doses are quite low. So
you're right, intentionality and being, as you said, quite explicit and open and transparent with that intentionality to, as we said before, do no harm initially, but honour what might be an eventuality as the end state pathology. That's, I'd never heard of the doctrine of double effect, actually. So this is learning to me as well, actually. Can
I just add to that? Just something we've seen coming up in cases a lot more is the kind of rise of misinformation on social media, and we've actually had quite a few cases of patients, families declining patients to have these medications because of that misconception. So I think something we spoke about, I believe in the last episode, was around that, like you said, Natalie, that communication with family and being really clear as to why we're giving it, what it's going to do. And especially with midazolam, that it actually, if we're giving it for something like agitation, that it may well settle them enough that they then go on to die because they've not got this stimulus, this agitation. But I just thought it was interesting that we're seeing that coming through a bit more as themes about this misinformation that's going on about these medications and what the intention is of palliative care. And that's probably something we're probably going to see a lot more. So it's important for ambulance clinicians or anyone giving anticipatory meds that they really are very clear with their communication.
So let's pivot slightly and look at shared decision making, actually. And this is almost a cornerstone, really, of where the podcast is right now, but also clinical practice, because especially in complex cases, 2, 3, 4 heads are better than one, especially bringing in experience and knowledge. Could I get you to speak to, maybe Natalie, to yourself initially, just really who should be part of that decision? And keeping it is complex. There's some immediate needs and some extended needs. Could I get you to speak to just really? I'll come to yourself, Karina, a second about the family. But Natalie, just your the initial pivot to the clinicians. I think sounds like they did the right thing, escalating quite quickly, some immediate actions and then quick shared decision making. Yeah. Could I get you to sort of unpack that?
Yeah. I think it's important to always involve the specialist teams for advice and support. I think I'll just make it clear now that in LAS we don't accept verbal orders, but we can accept advice that's clearly documented already on a MAR chart in terms of what dose to give next, but it still remains the clinicians on scene's responsibility around whether they take that advice or not, but equally can escalate that internally. But in terms of the palliative care teams, naturally this would sit quite comfortably with them. I understand it's not a very comfortable situation, but this is what they're routinely are involved with, and for them giving advice around how to manage something can be quite easy, over the phone. And I think what's important is, or what the message probably we need to give out is that sometimes we can't always follow that advice just because of our own internal governance, policy, structures, etc. And sometimes it's helpful therefore to have those MAR charts put in place a lot earlier on and have them completed, because this was where these clinicians unfortunately weren't able to administer the medications because the MAR charts weren't available. But I think it's always important to seek their advice because they have the specialist knowledge. And when you get that advice, if it's something conflicting about it or it doesn't quite fit right with how we as LAS work, then my advice would be contact internal support through the CSD, through the advanced paramedics, just to sense check whether the advice you've been given is accurate and whether you can follow through on with that.
And I think adding on to that, it's us being, as ambulance clinicians, being really clear on what the ask is. And I think that's something that this crew did really well, is explaining the situation, explaining the challenges, and saying, actually, I've never seen this before. This is really complicated. It's okay to say your recommendation is, I need some help. I don't know where to go with this. Or are you recommending that, in other cases, are you recommending that they're referred to the palliative care team? Or it's really conveying very clearly what the challenges are and what you're struggling with, rather than just giving a generic handover and leaving it up for the palliative care team to kind of figure out what you're asking. It's being really clear with that ask, and sometimes that ask is, I don't know where to go with this, and that's okay, and that's what they're there for. They're a specialist team. That's what they're there to help out.
This really important point, actually, because I learned this very much on HEMS and also as an APP, advanced paramedic in critical care. Is, to your point, front load the question to the reach back, or indeed to the consultant, because you're right, you don't want to be on the other end of the phone, not really understanding what the ask is. So actually being, we have a seizure activity, I'm not comfortable with medications, I need some guidance, I don't know what next to do, can you please help? 24-year-old male, but quick transferal of the absolute priority that you're uncomfortable with, because you're right, otherwise you're left to unpick on the other end of the phone what the true problem is or issue is. I think that's really powerful, and it needs to be front of mind when you're escalating. Absolutely. So Rowena said something really interesting earlier, and Karina, I'll come to you about this because you also said it is really bringing the families on the journey, being transparent. Rowena's got lived experience of this, and bringing them on side whereby there's shared decision making. And there's also decision making which kind of aligns to family wishes as well. And could I get you to speak to really not even just checking in with family, building quick rapport, aligning with their wishes, and getting a real semblance of what they're understanding, their wishes, and bringing them on that journey?
Yeah, I think in this case it was incredibly difficult because you have got essentially a time critical situation in front of you, but you need to absolutely bring the family on board and explain your decision making throughout. And I think it's something we're, again, I would say quite skilled at with all of the kind of cardiac arrest management we do, is involving that family throughout the journey. I think it's having that really open, honest, clear communication, but there's some questions we can ask sensitively that we can gauge where the family are at with things. So questions like, what's your understanding about your relative's illness? I can see they're under a palliative care team. What do you understand? Do you understand what that, what is their involvement? What does that mean? So asking those really open, wide questions so you can gauge, okay, they're on the same page. They understand that this could be a terminal event, or actually, no, they don't have a complete picture of the understanding, and then you can slowly try and get them to where you are. So it is, you're breaking bad news bit by bit in some of these cases. I think from my understanding from this situation, the family were quite well versed in what was happening, that they had been through this before, and that's all credit to the palliative care team that would have done a huge amount of work in getting that family there. But we often go to patients that rightly or wrongly aren't under a palliative care team, either because they don't need to be or because something's happened more suddenly, and that's where it makes our job really tricky, because we might be the first persons to be sensitively breaking that bad news that actually they might not survive this episode. And that's really tricky to do when you're also trying to manage a patient actively seizing. So not to say it's easy at all, but those techniques like asking those open questions to gauge that understanding, and then giving those warning shots of, I'm really worried about them, or I'm afraid I've got some potentially bad news. They may not recover from this seizure, which it sounds like in conjunction with the palliative care team, the crew did really well in supporting the family.
And just bits of debates that we tend to have in the team sometimes. Not debates, but we tend to talk about what words do you use? How clear do you think you need to be? Personally, I normally say, just be honest, use the dying. But sometimes, we've talked about amongst ourselves, you don't know who the family is, and maybe they need a slightly different approach in terms of how you communicate that. So it's always interesting. We always have these talks.
It's an ongoing debate, isn't it?
Yeah.
Because I think what we teach is to use the D words, dead, dying.
Yeah.
But certainly, Jodie, you have a slightly different view from your experience, don't you?
Yeah, and that's just from me personally. I find that word too harsh, and I think to be on the receiving end of that immediately is too much of a shock. So it's, yeah, absolutely. You don't want to use misleading language where then it leads families not understanding what is happening. But it's a very fine line to reading the family that you're with at the time. And I think it's all about those warning shots and just slow, small steps to bring them to where they need to be. But yeah, absolutely, to use words, there needs to be clear language, but but delicately done still at the same time. And that's it's a fine
There's
line.
no right or wrong answer, is there? You judge the situation based on the family you've got in front of you, like you said, Jodie, and that can be really tricky when we've just met them and been in the house for 5 minutes.
No, you're right. I used to sit the families down actually, because the same 5 minutes gives the family a feel. If you're sat down, the non-verbal inference that they are your sole priority, and actually also with you're right, Jodie, that really loaded and very difficult D word. Sometimes families need to not be stood up. They need to sit down because it's such a big word, and the ramifications and implications are so big that you're right. You just need to let them sit with that word and sit with the implications of that word. But the studies have been done to say that if you sit down with families, that same 5 minutes gives them non-verbal inference of longer time periods and the sole attention. But it's powerful, it's difficult, and there's a lot of emotional intelligence that needs to be applied to that situation. So just finally, before we pivot and look at this second case study, just a few final thoughts. One would be on questions really. Before we look at just reflections, involving the specialist palliative care team in real time is a powerful pivot actually. And something just to innovate once you've addressed the immediate needs, some of the longer term, and just get a full picture of the scene. But could I get you to really both speak to what you felt went well, and what might you approach differently to this case next time? But let's just start with what went well. And Natalie, I'll come to yourself in this clinical case.
I mean, actually, I think a lot of it went well. The case was just very unfortunate, but the paramedic on scene worked within their guidelines. They escalated appropriately. They conveyed their limitations accurately. They communicated that to the palliative care team, and that's sort of, I guess, a bit of how we got a bit more context was the palliative care team had approached us about, the paramedic saying, I don't think I can give this, or it's not within my guidelines, or I'm not comfortable giving this, or I'm worried about, the eventualities of me giving such a high dose. But they appropriately escalated it to an APP who came out to scene. Documentation was also quite clear, actually. The patient had a UCP.
UCP?
A Universal Care Plan.
Universal Care Plan.
Yes. Yes.
Yeah, it's fine. Yeah, it's fine.
So, and at least they also had the drugs at home, which I think was good. But then we can go on to what probably didn't quite go well. But I wonder if Karina has anything to add about what went well.
I think everything you said. I think the crew did a fantastic job in managing a very complex situation and escalating it very quickly. I think that was the key, and that the fact that they were supported by our advanced paramedic colleagues quickly as well, and the advanced paramedic was fantastic and worked within their higher PGD and kept that liaison with the specialist palliative care team. So I think a lot of it went well. I think what potentially could have gone better, which is why we spoke with the palliative care team, was more on that side of things, was the incomplete documentation, and also the palliative care consultant attempting to give the ambulance clinician a verbal order. So I think we spoke about verbal orders before, where that you're advising someone to give a medication which is outside of what's on the MAR chart, outside of our clinical practice, which currently within our trust we don't accept. So that was learning for that consultant. I think on reflection, she was quite distressed about the situation, and saw those, how those mistakes had led to that crew being put in a really difficult situation. But it was great that she came to us and we were able to immediately feed back to that clinician and say, this was a really tricky case. Are you okay from a welfare perspective? And to reassure, having that information from the palliative care consultant to reassure that actually this lady then went on a syringe driver with massive doses of midazolam. So that dose that he gave wasn't going to affect that lady in terms of hastening death at all, which was his main concern. So it was a really great example of joint working with a palliative care team to be able to feed back to the clinician the outcome, hopefully alleviate some of the fears around medication, but also learning on the other side of it of actually what do we need as ambulance clinicians to handle these emergency situations better, and to reduce the stress on us as clinicians.
And that really was going to be my final question for this case study, really, was because you're right, it's tricky. There's immediate needs for the patient, and then there's extended, and especially coming in cold to a scene where there's seizure activity. Oxygenation is a key consideration, but there's appreciation of the universal care plan. There's it's multifactorial, and actually you're right. Addressing immediate needs, quick MDT, start to step back, engage the family, start to really understand the trajectory of care and where you're going with this patient. So just to be explicit, so this patient stayed at home on larger amounts of midazolam over time. My final real question is to both of you, really. Has this case study in any which way changed your approach to either education or indeed to protocols or indeed to communication to the wider London Ambulance Service around these complex cases? Is there any learning that you've kind of brought forward into practice?
I think for me, there's a couple of things. So we have got kind of an e-learning package coming out for our staff around medications, and let me start again. So for me, I think there's a couple of things. I think the use of anticipatory medications, we've got an e-learning package, as we know that's an area that clinicians don't feel comfortable with, especially the doctrine of double effect and the information around us not taking verbal orders. A lot of clinicians would have been on the phone with a palliative care consultant and agreed to that, and we can't blame them because you've got a consultant on the phone telling you've got a patient seizing in front of you, you're going to follow that order. A lot of clinicians would do that. So it's around education around that side of things. And I think for me also it's kind of made me think about working with our critical care colleagues a lot more, because they are more likely to go to these actively seizing patients as opposed to our urgent care colleagues, who we focus a lot of our education and training around. So it's kind of got the ball rolling in thinking how can we do maybe some simulation or work with them a little bit more closely.
Fantastic. Natalie?
I think probably I'd focus more on the externals, stakeholders. So it's the palliative care team's understanding about issues around verbal orders, understanding that we can't give doses outside of the MAR chart, and what we're limited to if there is no MAR chart in place. And it's probably an education for them to understand how much an ambulance clinician can do. So I think that's something that we'll probably be taking forward. But it's a big London, so, so hopefully something like this might help push that message out there.
Yeah, fantastic. So let's pivot and look at the second of our clinical case studies, actually. And I'm going to engage Rowena and Jodie very much more, as well as the wider team in this second case study. So the second case study really is around an 84-year-old woman, multiple comorbidities, and high level of fragility or frailty, and suffers a cardiac arrest at home. The crew responds, so the ambulance crew responds and initiate basic life support for the patient, but do not attempt CPR, anticipatory meds, and PCT details are found. So they are found, but there is basic life support ongoing at this time. The daughter is present on scene and has a strong Christian faith, and she requests of the crew that her mother remain at home for several days. So there's no legal barrier, but there really is navigation around communication and public health considerations. And before we get there, let's look at the clinical treatment. So basic life support is, and I'll come to yourself around this. I've certainly been in this situation where it takes a while to understand that there is a DNA CPR, do not initiate CPR, and there's also semblance when you appreciate the wider situation, but it stops you escalating treatment to giving adrenaline, which might be inappropriate, to intubation, to advanced life support. Could I get you to speak to sort of really taking stock before you escalate? We'll dig into this, lots of nuances of this case, but can I get you to speak to really not necessarily migrating from basic life support to advanced life support, to take stock of a scene and then to appreciate that actually an escalation of care might not be the right pivot before we get into some of the complexities?
Yeah, absolutely. And I think it's something that we are faced with probably not infrequently. And they're big decisions unless it's immediately obvious and someone hands you the DNA CPR as you walk through the door, which obviously makes it significantly easier. But I think a lot of the things that you've already mentioned in terms of evidence are key to that decision making. And I think what we would really encourage is, if you've got that gut feel that this is not appropriate, just hold at BLS and gather that evidence. And I think, like Natalie and Karina both spoke about, being that detective. And I think pre-hospital clinicians are just innately very good at gathering all of that information and all of that evidence really, really rapidly, because it leads you to get to those decisions. So in terms of what you'd be looking for in terms of that clear evidence of an advanced and irreversible condition. So obviously, as I said, if you've got that DNA CPR decision, that makes life a lot easier. Obviously, you've got to make sure that it's valid and applicable, and none of those pertinent situations such as choking, where you would still need to address the cause of cardiac arrest, but again, still hold at BLS and escalate as appropriately whatever that is within your service, your trust. But in terms of the evidence, you'd be looking for anticipatory medications, which in this case were present, details of a palliative care team, and get them on the phone as quickly as you can. Details in hospital discharge letters are also really, really key to kind of assimilating all that information nice and rapidly. And I think pulling all those things together to kind of form that picture of that patient, including, again, as these guys have spoken about in that first case study, it's taking that history really quickly. What's happened in the last day, week, fortnight? Is it a general decline, or is something happened really rapidly today that you need to consider within your treatment? But I think gathering that evidence is key.
Yeah, absolutely, and I couldn't agree more, because and it's easy to say this, but very much more difficult in practice, because you're right, you were a moth to a light bulb in a way. There's a patient cardiac arrest. You want to really, step up and escalate care as promptly as possible. But to your point, Rowena, it's really prudent to take a step back, do a baseline of activity, basic life support, to your right, to widen your focus, to see if there is anticipatory meds, to see if there's a hospital bed, or indeed some semblance of palliative care, and get optics on the wider situation, really. And I started to really refine that kind of pan out perspective, where you can just really appreciate the wider scene, because absolutely you can be consumed with the patient at hand, and you negate the wider scene sometimes. So it is taking your time just to take a breath, take a step back, and then bring the crew, as you're saying, bring the crew on board with you, and understand with them that actually this is the ceiling of care right now, or sorry, ceiling of intervention, not necessarily of care, because care is extended, ceiling of intervention, and then redefine how that might look together with the family, and then actually that this is the end of the road, and the D word needs to come into play and just really start to bring the family on board. I actually shift, Jodie, and come to yourself, and actually just really ask you about your perspective on bringing the daughter on board here, because there's cultural and religious wishes that come into play. But could I just get you to initially speak to, this clinical case? We've decided this is the ceiling of intervention. We pivot now to the daughter. How would you unpack things with the daughter?
So it's all about communication. It's clear, concise communication, and that is involving when we're talking to colleagues as well, because ultimately everyone, the team that's there, all needs to be aware of what's happening, and all can contribute and to a decision that's going to be made, and absolutely taking on the loved ones that are on scene. And in this case, it was the daughter. Initially, she was actually on the telephone, which obviously puts a barrier to the communication. She cannot see what is happening, so that made it difficult, and that's where maybe some cross wires were initially had. So I think the DNA CPR it came about quite late, so that history gathering took a little bit of time for the crew. So I think it's clear, concise communication. It's then as a clinical team making that decision, then obviously absolutely including the family the whole way through. And even when there is basic life support being administered, it gives that time as well. It allows a little bit more of a breathing space for that family to start seeing what is happening and start coming along and thinking, okay, this is now what has happened. It can absolutely sometimes help that family in that situation.
Absolutely. No, absolutely. And to Karina's point earlier around just aligning, you can start to align with the family and start to, bring them on that journey. Absolutely. So I'll pan out, actually, let's look at the wider implications, public health implications and legal implications of keeping a patient at home to honour and respect the daughter's wishes. Rowena and all the wider team, could I get to speak to just, the public health implications of keeping a deceased body in a public address, in a private address at home? What are some of the considerations that clinicians should think about?
So for this particular case, so basic life support was terminated, and the death was verified, by which point the daughter arrived on scene. But as what we commonly do, so we've gone in, haven't we? We've gone in, we've seen a resus, we've started basic life support. We're very quick and eager to try and escalate to advanced life support. History gathering allowed for that not to take place. The daughter then arrived on scene. But what happens, I think what we do quite commonly is once we verify, we're very quick to then get in contact with control and request police to scene, treating the death as an unexpected death. For this case, the daughter then arrived on the scene, and then more evidence become apparent that actually they were under a palliative care team. There was anticipatory medications there, and this death was very much expected. Although to look at, it wasn't classically like when you walk in and a patient could be hectic in a hospital bed, all those key signs. For this particular patient, that wasn't the case. They didn't look, to use that sort of word, as it would be an expected death. So that threw our clinicians. So the police had unfortunately been requested to scene. Then the daughter arrives to say, under a palliative care team. Our crew then contacts a palliative care team, have that confirmed, but by which point the police are now on scene. So then the daughter had said that they'd had their chosen funeral directors that they had chosen that they wanted to use for their loved one, and actually there wasn't going to be a rush for that they wanted to keep mum at home for a few days. Now that obviously is a very unusual request, which did frighten, I would say, our crews. They were very concerned that absolutely wasn't done and shouldn't be done and couldn't be done. Thankfully, they did escalate to our control, and they were given the instructions that you can respect the wishes. But at the time, the daughter asking this request, the crew were very much, I'm not really sure. I don't think that's happening, and took a stance of that's probably not going to be allowed to happen. Unfortunately, the police were here, so this did change the situation, because once the police are on scene, it's unusual for them to be able to step back. But the reality was that actually that was more than it was allowed. That lady could have had her mum at home for multiple days if that was their wishes. And that is something I think for us to educate ourselves on as clinicians, and just for the wider public awareness as well, as actually care after death can look very different to how it's perceived and how it's commonly done. You do not need to have a funeral director involved. You can keep your loved one at home with you, whether that's for 1 day, 2 days, several days. Yes, there are considerations, and we can talk about things to consider and advice that you can give to families in that situation. But I think it's important to make people aware that they have got a choice, and there is a difference. And it makes a huge difference to people as well.
So let's just look at, just to really double down and zoom in on that, actually, Jodie, just how you really your phraseology, and I know it's semantics, but it's actually quite important, actually, because to your point, there's if it's both legal and possible, there is an affordance of trust and of wishes, of family wishes there, because it's atypical, but it doesn't mean it can't happen. So what would you, just to make sure you don't influence the conversation, and you don't get almost your own wishes and beliefs tangled up in what they might want, because it is possible and feasible that this patient stays at home. Could I get you to speak to just the phraseology and or the semantics that you would use to really, I guess to Karina's earlier point, just use open, wide questions, and and almost allow, be permissive in your language. How would you approach it?
I think it's really difficult with phrases, and we're individual clinicians and we're treating individual patients and their families. So like we said earlier about sort of reading the room, and that is absolutely key in every person and every family that you're invited into their home, and that you are part of somebody's death, is to learn about who they are, and then to adapt your phrases appropriately. And I think the first thing that you're often asked is when someone has died is, I don't know if it's the same for yourselves, but I think my first question I find that the people ask is, okay, what do I need to do next? What's next? And obviously they're in absolute disbelief of what's happened, even though it would have maybe in the patients we're talking about, these are expected. It's still disbelief. So I think I always say to sit down, and there's nothing to do for the minute, and just give them time. It gives you time, because then there's no quick wrong decisions being made. And I think that would be my first advice, is to say there's nothing to do right now, we're just going to sit, and then see what the next steps would be naturally. Obviously they want to go down they want to know what's next and what to do, but you don't have to make rushed decisions. Don't hold fire for contacting the police, and that would be the biggest take home is don't be quick to treat this as an unexpected death. Just wait, gather all your evidence, gather time, speak to the GP if it's in hours, but don't be quick to do anything. So I think in terms of phrasing, and it's difficult because it's each and every own, like you'd have a different way. Be natural. Know that now this is your part of now someone's death. It's a very privileged place to be. It's a very sacred place. So yeah, choose your wording carefully, but don't maybe overthink it. Let your own human caring nature come out. Don't think too much of it.
Yeah, I think that's powerful actually, and absolutely true. And you're right. If there was ever a time to be human, and just to relate to another human, it's right now. It's not about being a clinician. It's about being the human in the room, as you were saying.
And I think just, I mean, your point about being human is that was the initial reaction from the crew was, oh gosh, we can't leave a deceased body at home for 2 days, because we've never experienced that or never had that for our loved ones. So they were very much, like you were saying, putting their own experience, wishes, beliefs onto that family initially, weren't they? And they reflected on that in the debrief.
Yeah.
And I think that was one of the key learning points, was being open and non-judgmental, and absolutely they were right to escalate it if they were unsure, but it's having that non-judgmental approach. And you know, we work in London, it's so many cultures and faiths and beliefs, and I think it was a good reminder for us that actually throughout our education, our teaching, our key messaging is having that non-judgmental, curious approach would have maybe helped the family in this situation, because I think the daughter was feeling a little bit distressed that she was being questioned or being told she couldn't do something, being kind of shut down initially, she felt, and that's how it kind of came through to us as a bit of a complaint almost. So having that curious, non-judgmental approach with all of those things you were saying, Jodie, about being human on top of that, absolutely.
Can I just add to that a little bit with the word curiosity that I think strikes a chord with me? I think we used to talk a lot about cultural competence, and I think that's shifting now to cultural humility, and I think that breeds curiosity. And like you said, Karina, we work in London, it's massively diverse, culturally diverse. You can't expect anybody to know everything about all of the different cultures, faiths, religious beliefs, whatever that might be, about every culture. So it's okay to not know, but as Jodie said, take the time to be curious and non-judgmental and elicit that information and really understand what's important for that family, because that is what they will remember going forwards. So I think curiosity is absolutely the right word for it, and just be interested and then reflect on that yourself, and that will develop you as a clinician as well as making that kind of initial immediate impact on that family.
So let's follow that theme actually, Rowena, and just look at really bereavement support actually, and just because Jodie said this, and I fundamentally agree with this. It's actually not putting, everything within preschool care is measured by time. Time on scene, time to scene, time at hospital, time to hospital. But actually, you're right. This is the time to not measure those metrics and actually just give people space, be the human in the room. Could I get you to speak to bereavement support? Because one of the fundamental challenges, and we spoke about this on other episode, really, is that we're there for a fixed amount of time. This bereavement is long lasting. It's life lasting. It's going to last the rest of their life. We're there for maybe the initial hour, 2 hours. Could I get you to speak to bereavement support as much as active listening, as Jodie was saying, but B, signposting, but just being that being empathetic, sitting down, making a cup of tea. Maybe that's a very British thing. It probably is a very British thing, but just extending empathy, signposting, and just things that might not initially be top of mind, but probably need to be.
I think don't underestimate the power of a cup of tea.
Yeah.
It's an essential part of any ambulance clinician's toolkit, I think, is even just offering, whether it's tea, whether it's a glass of water. It's not the tea, it's the offering. I think it's the act of, it's a supportive action, isn't it? And it's saying, I'm here and I will be here, even if that's for a comparatively short part of time. And actually, Natalie said something really interesting earlier. I think we get caught up in what we can do. We love doing as pre-hospital clinicians. We get in there, the adrenaline's high, we do. And actually, sometimes it is just being there. It's just talking. It's just listening. It's just making a cup of tea. And those things I think really need to be championed because they're so important. And what might feel like a long job to you because you're used to 20, 25 minutes on scene, quick turnaround, go to hospital, taking an hour, 2 sometimes can make a huge, huge difference. Maybe don't tell that to my bosses too much. But it is massively important, and it does hugely impact the next part of the journey for family, I think. Just having someone there who cares, and we are uniquely placed as pre-hospital clinicians that in that moment we are just there for that one patient, that one family. We're not managing a caseload, and we can be there, and we can just participate in whatever needs to happen. And as Jodie said, take that time. Nothing needs to happen immediately. I think if patients are under specialist palliative care teams, they play a huge role in bereavement support for families beyond the moment of death. And that's a huge part of their workload, I believe. Correct me if I'm wrong, Natalie. But I think they play a huge part in that and that kind of ongoing process. And that's hugely valuable, I think. And there's a huge amount of bereavement support out there beyond that, whether that's, I see a lot of charities provide various different support. And there's absolutely a place for signposting on to those things as pre-hospital clinicians. But actually in that moment, I don't know whether it's helpful. And I genuinely don't know the answer to that. For me, it wouldn't be helpful. It would be too soon to think about that. But absolutely have it in your armoury ready to go. If someone says to you, what do I do next? You can give them the practical tips, but actually then saying, and in the future when the time is right, these people might be able to support you, or contact the GP or contact the specialist palliative care team who will guide you through that really tough process and be there.
So just as we come into land on this case, before we just really wrap up with some tips on top of mind advice for listeners, just if I could just come to you both and really just ask exactly what I asked Natalie and Karina really about. Maybe let's just look at some things that went well and some things that either were challenging or that we could approach differently or think differently about. But maybe Jodie, things that went well in that case, could I just get to summarise?
Yeah, things that went well is that they held at BLS and they were able to gather that information. They did escalate when they felt unsure about what was being asked. They absolutely supported the family and did what they thought was best for the patient and for the family as well. I would say that was the two standouts.
Yeah, absolutely. Yeah, absolutely. And things that maybe we could consider to do differently, or indeed there were challenges and that have prompted us to think differently retrospectively. Rowena, anything to yourself, or indeed Jodie?
I think it's the building in the pause, isn't it? It's in this situation and in multiple others. The quick decision to think, oh, okay, this is an unexpected death. Because, like you say, it's that constant clock for us, isn't it? You're going in, and this was a category 1. It's a cardiac arrest. You've your pads on. It's on the chest. Everything's go go go. Then very quickly, it's not go go go. I can now stop, but you're still going inside, aren't you? So then to actually slow yourself down, and now you're applying a whole different set of rules. So I think for this and for everyone, when you are in these situations, and particularly with palliative and end-of-life care, it's just pause, just build in, slow that clock down for yourself, for the patient, and most importantly, so you are not rushing decisions for the family, because that will have, like Rose touched on, such a long-lasting impact on their bereavement process, and they will live on, and everything will be remembered about that point in time and the part that we play. So, I think it would be pause before acting.
Yeah, I totally agree. I think that pause to, if nothing else, to manage your own adrenaline and clear your own mind so that you can make the next decisions with as clear a head as you possibly can. And in this particular scenario, making that decision between expected and unexpected death, what's the rush? if it takes 5 minutes because you need to gather a little bit more information or clarify something, that's not going to change the outcome, unfortunately, at this point. So there's absolutely nothing wrong with taking a little bit of time. And I think that's really difficult to do when we feel that time pressure, because there is an expectation that, you know, we're an emergency service. We need to be on to the next one. And to a degree, we absolutely do. But actually 5 minutes isn't going to make a huge difference to the wider system, but it will make a huge difference in that moment. And I think alongside that curiosity, that professional curiosity that needs to come into every part of every job that we go to, whether that's clinical curiosity or cultural curiosity, I think they're equally important, and they go together to kind of create this overall picture of a patient that can then guide your decision making.
Oh, that's powerful. That's powerful. And then I really like that clinical curiosity and cultural curiosity, because you're right. They're two distinct things very much, and they've both have got completely primary ramifications to get those right, because, you know, derivation of either will cause a lack of rapport and a lack of optimal outcomes. So I think you're right. The clinical and the cultural aspects are both equally as powerful. It's really important that you said that, actually, Rowena. Okay, just as we really come into land, actually, for the last 10 minutes of the podcast, I'd just like to go around the room, really. I'll start with yourself, Natalie, and just really, I guess, in a way, a top of mind piece of advice, just one piece. It's really difficult, isn't it? The one piece of advice. There's never just one piece of advice. But could I just get you to just to leave listeners with, you know, anything, if a clinician is faced with an urgent and or emergency palliative and end-of-life care case, is there anything to your mind that they should keep front of mind?
I mean, there's so many things I can say, but what I'd probably say is there's always somebody at the other end of the line. Call somebody.
Yeah.
Sense check it, talk it through.
Yeah, that's powerful, actually. Yeah, that shared decision making, and absolutely, and especially in the complex cases we've been through today. Absolutely. Karina, to yourself, anything that would make the biggest difference? We've talked lots of things: power of the pause, the cultural and clinical pressing. There's so many things, but could I get you to speak to just something that's top of mind for you?
I think my reflection is everything that's been said, is that you don't have to, as an ambulance clinician, it can be quite a lonely place attending these patients. It's not all on your shoulders. And I would, you know, echo that, sharing the decision and having that. It's a bit of a paradigm shift going from usual pre-hospital work to attending a palliative care patient and asking people to pause and slow it down, but just remembering that's okay. So I know that's kind of repeating what we've said, but it's for me that's the biggest thing. I think our clinicians get caught up thinking they should know all the answers and they should know what to do in these cases, but it is a bit of a grey area, palliative and end-of-life care, and that's okay. You don't need to know everything, but contact the people that do, the experts that do, and also try and get out of that emergency quick rush mindset, which is not easy.
Jodie, to yourself.
I think mine would be, and it's particularly for palliative and end-of-life care patients, would be actually you're the human first, and you're the paramedic or the ambulance clinician second. So you will do so much good and support if you just turn up and be kind and caring, as that's what drove you to come into healthcare in the first place. All the other additional skills will come on, but yeah, to be that human first and to be there for people.
Rowena.
I don't know how to follow those three. I think they've summed it up beautifully. I think there's something in recognising that privileged position that we are in being in that moment with that family, and for a little brief snapshot in time, you are part of that family. And actually how you are, whether that's, as you said, Owen, sitting down with them, having that conversation, or like you've said, Jodie, about the choice of words and reflecting back perhaps what you've sensed that family is ready to hear. Don't underestimate all of those non-clinical skills that we possess. and just be really honoured that you're part of that and commit to that moment, I think.
Yes, and that's powerful. It's powerful. And I just want to thank all four of you, actually, just not only just for today's session, but also journeying through the past 3 episodes with us, with the Pre-Hospital Care podcast. I think this is such an important aspect of pre-hospital care. And Jodie, to your point, Rowena, to your point around if it's de-escalating the expectations, but it's also understanding the importance, because the reverberation and the echoes for the patient echoes through their lives, and it's such a finite amount of time for us, but it's such a protracted amount of time for the families. So it's really powerful to get all 4 of your lived experiences on the podcast, to get your thoughts and also just your insights, because actually they're super applicable to clinicians on a day-to-day basis. So Jodie, could you speak to just the public health implications of keeping a body in situ, so on scene, for maybe a protracted amount of time?
Okay, so it is unusual and it is very rarely done, but it can absolutely be facilitated, and that will be totally family dependent. So the practical tips that we would say is to, obviously, you want to shut out sunlight, so darken the room, remove any heating, aircon if possible, keep windows closed. You can lay the person flat but just slightly raise the head, but obviously be aware that we know that fluids can build up and may escape from the nose and the mouth. So to warn the family of that, and maybe put some tissue or something around to protect for that happening. You can put sort of wrapped frozen peas or any frozen vegetables or anything frozen, wrap and place on the abdomen, because obviously any changes initially start in the stomach, so we can just slow that process down. But yeah, there is nothing against doing that. And way back, years and years ago, that would have been traditionally done. You would have kept your loved one at home. And I think there's something really very special and unique if you feel comfortable to do that. Obviously, everyone is very unique, but I think it's nice that people are aware that that is a possibility and that your loved one doesn't have to be whisked away quickly, which can often happen. And then, yeah, even though you know it was coming, they've gone. And actually, to say to families, they can stay. Like, invite friends and family, whoever you feel is important, invite them round, and it gives an entirely different perspective and will mean, a hell of a lot, and change their process incredibly. So, but yeah, the practical tips are there for the clinicians, and the emotional side of it for the people.
So thank you to all 4 of you. Thank you so much.
Thanks for having us.
Thank you.